Okay, our final talk for this session is going to be by Dr. Waleed Alharbi. Dr. Waleed is the is interventional cardiologist and director of King Fahad Cardiac Center. So he's going to give us a talk about how to select the appropriate wires, balloons, catheters, and devices in heavily calcified lesions.
Assalamu alaikum jami'an. Thank you for having me. I'm left with a talk that after my colleagues, I'm not sure what I'm going to add. It was really amazing speakers. But I'm going to try to have a practical approach to what I've spoken earlier. So the learning objectives I'm going to talk about is that when to recognize the calcification, and that's a problem, and already been talked extensively about it, and how you're going to plan your attack when you have that issue, and what's your contingency plan once the complication, if there's any complication going to happen. Because if you go through this, you will not be surprised with unsatisfactory results. And this was predicted 50 years ago by Dr. Grunzig. He mentioned that at present, the technique is limited by anatomic factors such as calcified stenosis. This is when the first balloon angioplasty series have been done. And since that time, we're talking about it, we have a large armamentarium to deal with this subset of lesions. So when to anticipate the problem? So you can see on the left side of the screen, you can see the calcification during only cardiac motion in one side of the vessel, and that's where you call moderate. Or with a still image, you're going to see without the cardiac motion both sides, and that's where you're going to see severe calcification. So how reliable is fluoroscopy? That's the key. So before I go to answer this question, I want to raise of hands who faced that he had a STEMI and went into direct stent and have a surprising underexpanded stent. Raise of hands. Okay, very good. So it means that they've been seeing cases. So half of the patients, we don't see the calcification on fluoroscopy. So we fail to identify. So fluoroscopy is not reliable. So we really have to, if you suspect it clinically, for example, old age, diabetic, patient with kidney disease, or if you're really suspecting that, proceed with intracoronary imaging. And the problem is that third of our ACS population, they have moderate to severe calcification. So you're going to face it. And when I started my career, I was really making that shortcut, which is not right. But especially in our population, we have more patient diabetic, and they have more extensive calcification. So it is very crucial to identify the problem before you embark. The reason that if you do balloon dilatation, for example, you're really going to limit your plaque modification strategy initially. Calcium detection by intracoronary imaging, it's about more than 2/3 of patients, you can't detect it by IVUS. And almost the same with an OCT. And with fluoro, as you mentioned, it's about less than the half. So still, not 100%, but at least you're going to pick up the most with intracoronary imaging. I'm not going to go into details about the different types of calcium because that's where you have your strategy going to differ. But as my colleague earlier talked about why calcium is a problem, is that the challenge of equipment delivery and the challenge of the lesion expansion and the complication might happen with it. So these are the three major things, and that's why when you do your planning, it's based on those three. And you need to prepare the lesion. And to prepare that, you really want to have a successful stent delivery, and that's the struggle when you have a procedure prolonged because of that issue, and have an adequate stent expansion, and to try to prevent any complication with that. And we have a large armamentarium for that, from balloon angioplasty to balloon plaque modifiers, and then the devices including rotational, orbital, or lithotripsy. So Dr. Black usually have a very beautiful way to approach any procedure. You try to have a mental simulation of the procedure, and based on that, you plan your attack of the problem. So we'll start with planning. So the first time you want to decide your initial strategy. You identify the problem, and then you want to say, am I going to a primary atherectomy immediately, or you want to do a secondary atherectomy, which means that you're going to test it with a balloon. If it goes well, then you escalate. If it goes well, then you're good. If it doesn't, then you go to atherectomy device. And Dr. Badr Zurhani talked about beautifully in his talk about the studies that looked at if you embark in a primary atherectomy strategy versus a secondary atherectomy strategy. And it was superior that you prepare, take your time with preparing the lesion, but the downside, it has its own complications. So how are you going to approach it? So if you recognize there's a severe calcification, then if no, then you just proceed with your regular PCI. If yes, then do you have tortuosity? There's a dissection. If there is, then try to go with a secondary atherectomy strategy, if possible. If you have it, the device can be delivered and cross and dilate. If it's not the case, then you prefer to go with a primary atherectomy strategy. Second, you want to optimize your support, and that's with choosing a guide and have a guide extension, the guideliner or guidezilla. Try to optimize your conditions as much as possible, rather than making a shortcut and then regret it afterwards. The next step is that try to take your time. Upgrade, upsize your balloons gradually. Do not rush. Go slowly, and when you do the balloon angioplasty, you want to enhance the efficacy of your balloon inflation. And to do so, if you found out in your intracorneal imaging that it's not nodular in nature, then the likelihood you might have complication less, but go high pressure as much as possible. And some people rush. Just within seconds, they deflate, and this failed, they go up with another balloon. Prolong your inflation time, minimum 1 to 2 minutes. Sometimes you need to do some cutting with body wires with it. It might help. And monitor the inflation device pressure itself. If you see your inflation device pressure goes down, it gives you a hint that there is a response. The lumen of the vessel is expanding. So give it a longer time and go back with the pressure again. If that fails, then you go to the next step. Use a plaque modifying balloons, cutting balloons, scoring balloons, and high pressure balloons. And when you use a cutting balloon, really it's a different way of dealing it. So you try to go very slow inflation, and the same thing goes with deflation. Because you need the blades to get out, it takes time. So go very slow and wait for a few seconds, 5 seconds for every atmosphere. And then when you deflate, the same thing, because you're going to wait for rewrapping. You don't want to get it back and cause damage to the proximal segments of the vessel. So what do you observe when you do the cutting balloon? You want to look at the balloon expansion, 1-to-1. Then once you really deflate, you can make that use of the chance to move the balloon. If you feel it's really smooth, then you anticipate that probably when you deliver your stents, it's going to be smooth. So that's a good test beforehand. You go ahead. And then you can confirm with intravascular imaging. So if you do intracorneal imaging and you see the fractures of your circumferential calcification, then you're good to go to proceed with stenting. But like anything else, there's no free lunch. You might have complications. And that's why you have to anticipate those problems. So balloon rupture, balloon entrapment, vessel dissection or perforation. So before that, you make sure that all your gadgets are ready to deal with those issues. And then you have the stent advancement. And that's where the struggle happens, especially if you have a tortuous, severe calcification. So the strategy to overcome that, you already planned it ahead with a good support, with a good shape, bigger French, and try to, when you deliver the stent, choose the stent shorter, if possible. You can put multiple stents rather than a long one. So you don't go and try to have the hurdle of advancing the stent. And make sure it's then with a stent optimization, take your time with post-dilatation with high pressure, confirm it with intracranial imaging, and that's what I call it, this is a La La Land result. But it's not always the result. That's why always be prepared for complications. So whenever you face a problem, if you feel that the patient have perforation, you're ready with that. And an example in this case, a dissection. So in summary, the key is recognizing the problem. And that's why I asked for a vote to see how many people have faced this. I faced it myself, and you're going to face it. But to minimize that surprise is that to predict it and to try to evaluate before you embark on any technical strategy. Plan it well, make sure you have the right inventory, and have a contingency plan if the plan fails. Thank you.
Thank you. Thanks, Waleed, for this lecture. Because we have a live transmission, I thank everybody. In summary, plan your procedure, look at the lesion, make sure about what you have in the cath lab and what is the best approach for a calcific lesion. I thank my panel here and I thank all the speakers. And I will hand this to the next live transmission I think we have. And thank you all.